Welcome to the Wild Physio podcast with your host, Andrew Wild. Today, I welcome Dr. Allan Young, who is an experienced and highly qualified orthopaedic surgeon specialising in shoulder surgery. Allan completed his surgical training in Sydney, then undertook international fellowship, post-fellowship training in advanced shoulder surgery in Lyon, France. He was awarded the Gordon Taylor Award by Royal Australasian College of Surgeons for achieving the highest marks in the fellowship examinations across all disciplines. He holds a master's in sports medicine from the University of New South Wales, as well as a PhD from the University of Sydney. Allan has authored numerous publications, book chapters that stem from his research and clinical work, and he's a director at the Sydney Shoulder Research Institute. I'm getting through it slowly. Combining his knowledge and skill with scientific evidence, he provides best practice methods in shoulder surgery. Throughout the course of his career, Allan has cared for numerous professional athletes and sports teams. A huge welcome to Allan. How are you?
I'm good. Thanks for having me, Andrew.
Looking forward to it, mate. We just had a long discussion before we even started the podcast, so I've already taken up half an hour of your time.
And much of that was to do with knees and ACLs, not
I know.
shoulders. So there you go.
Well, we'll dive into the shoulder stuff now. So we're going to start with the yes, no, or maybe questions. You can only answer with one of those, and then we'll dive into why after.
Right. Okay.
All right. So when I mention shoulder dislocation, I'm referring to a traumatic anterior glenohumeral dislocation for the listeners and also Allan. So we've got 8 questions here. First one, if you've sustained your first shoulder dislocation and you're under 25 years old, should you get a surgical opinion?
Well, that's yes. As a surgeon, yes. Can I say yes, I guess, or yes, maybe, or it's a yes, no, maybe?
Yes, no, maybe, but you could add a little bit if you want.
I'll qualify that. I mean, if you're seeing a good physio therapist or a good sports physician or a good GP, then not necessarily do you need to see a surgeon.
Yep.
So can that be a maybe?
Yeah, we'll call it a maybe. If you've sustained your first shoulder dislocation and you're over the age of 40, should you get a surgical opinion?
You know what? I would more be inclined to say yes for those, even though they're non-operative, because they're associated with some more other complications. Again, if you've got a good physio, good GP, good sports physician, I would say they're the equivalent of a surgeon for both those cases, but I'd be more inclined to say yes.
Okay. Should you use a sling for a first-time shoulder dislocation for longer than 7 to 10 days to reduce the risk of redislocation?
In my practice, no.
We'll dive into why in a sec. If one does not use a sling after their first shoulder dislocation, does it increase their chance of redislocation?
There are some papers that will say yes. My experience, probably no. For what many would consider a sling, I would suggest not.
Okay. How long could you trial non-surgical management before deciding on surgery versus no surgery after a first-time shoulder dislocation?
Well, I guess, so that's not a yes, no, maybe, but that's, I tell most patients that after first-time dislocation, they've got to accept that it may be up to 3 to 4 months before their shoulder quote unquote recovers. Some certainly get an idea sooner than that, but I tell them really, if they're going to commit to non-operative management, they've got to accept that it's a 3 to 4 month recovery process.
Well answered. And you're all over that. I thought you'd be stumped with that one because it wasn't a yes, no, maybe. I was writing that question. I was writing that question today, actually, and I was like, that's not really a yes, no, maybe. I wonder whether he realizes. All right, next one. If one trials conservative management for 1 to 2 years post a shoulder dislocation, and the person redislocates their shoulder 2 to 3 times in that conservative time frame, will that affect the surgical outcome versus having surgery earlier and without the redislocation after their first dislocation?
I guess the strict answer is yes, but with an asterisk. It still then depends on so many other factors to do with their imaging, age. So I guess technically it's a yes, but there are some situations, other factors I'm probably more interested than that specific question.
Yep. And this isn't a yes, no, maybe. How long could we trial non-surgical management after a first shoulder dislocation before deciding whether a patient should have surgery or not?
Well, I guess if they recover and their shoulders feeling good, then whatever time frame that takes, if by 3 to 4 months they still don't have confidence in their shoulder, that feels unstable, or what occasionally occurs, they have instability events in that around that time frame. I guess that's what my answer to that would be. So yeah, I'd give them 3 to 4 months, and it depends on timing, which can be the asterisk. I'm assuming if we then discuss it further, will be, how that discussion plays out in practice with each patient. So it varies on the patient, of course. Yeah.
And further to that, are there cases where conservative management shouldn't be trialed and surgery is the answer for a shoulder dislocation and a first-time traumatic one?
Yes.
Yes. Great. Well done. They are done. How'd you go?
Good. No, I felt happy with that.
Happy with those?
Difficult to limit those to a yes, no, maybe.
Yeah.
Because there are some nuances within each of those questions that will vary depending on patient factors, imaging factors, their sports, their desires, age. Yeah, there are a lot of those factors that come into play. That'll be interesting to speak about those, but particularly that question where you said, are there any indications where the answer is yes? Most often the answer is, I tell patients there's no reason that we have to do an operation, but there are some circumstances where I tell them that they really should. But that would be I would say the exception rather than the rule for shoulders.
Now, first thing that I want to dive into, what actually is a dislocation for the listeners? A traumatic anterior shoulder dislocation, what is it?
Yeah, well, I think that's what, I tell patients that the shoulder's a ball and socket joint. It's got the most motion of any joint in the body. So there's some, it's at a high risk of instability. And that instability that we speak of in terms of a traumatic instability essentially is usually anterior, but the occasional posterior dislocation can occur. I explain to patients, I say there's a spectrum. I say that you have the ball in the socket, whether the ball comes out, locks out, stays out, traumatic, needs to be put back in by somebody else, ambulance, paramedic, in hospital, or it's a subluxation where the shoulder partially comes out and then goes back in, or it's a dead arm feeling or a burn or a stinger type feeling. They're all the same event that's occurring. It's just how that process occurs and over what time frame, whether the humeral head stays dislocated. So if somebody said, what's a shoulder dislocation? I'd say where the humeral head has come out of its articulation with the socket and is locked out of position. That's what I would call a dislocation. Now you might, we're talking semantics, but you might have a dislocation that then spontaneously reduces. But that's what I would say dislocations. The humeral head has to come completely out of the socket, which usually involves a soft tissue lesion, the essential lesion of a dislocation being a Bankart tear, which is a tear of the labrum or the ligament of the anterior front part of the glenoid, and then typically associated with, I explain to patients that the bone of the ball is a bit softer than the socket. So when the shoulder dislocates, the humeral head's out the front, that bone hits the front of the socket and ends up with a divot or a dent on the back of the humeral head, a bit like if you had a ping pong ball and you stuck your thumbnail in. It's the remnant. So they're the two typical findings of a dislocation, but of course, there are variations as to how you tear that labrum. Some people can tear the ligament, in the mid-substance. Some people can tear that ligament off the humeral head side. So a lot of variabilities about how that occurs. And then, of course, there's collateral damage that can occur to the labrum elsewhere on the socket, the biceps, the rotator cuff, all these other structures that we then look for.
And how are we typically diagnosing this, and what clinical tests would you use in the clinic or imaging to confirm a dislocation?
Well, I guess it's going to be a bit different as to who you're talking about, whether it's physiotherapists, whether it's a GP, whether it's sports physicians or a surgeon. Most times, in most cases, by the time the patient comes to me, they've probably had that diagnosis made. Many now have already got their imaging. For me, an MRI scan is essential. Anybody that has dislocation, if they're coming to see me and they think they're seeing, this wonderful shoulder surgeon that's not going to miss anything, that's going to tell them exactly what they need to know. Well, I need an MRI scan if I'm going to give them all the information. One of your questions, I guess, for us, does a patient with a dislocation need to see a surgeon? Well, if you're a younger patient, you have a dislocation, then other than the possibility of that shoulder subluxing or dislocating again, there's typically not much more that happens in addition to the dislocation that we need to be worried about. Whereas if that patient's older, then they may have a tear of the rotator cuff, or there are some other things that are sometimes more critical than the actual dislocation itself, nerve injury, all those other things, for example. So by the time the patient comes to see me, I need to know everything about that shoulder. So yes, X-rays are wonderful. They should all have an X-ray initially after they have a dislocation to make sure the shoulder's back in position, particularly if it's a posterior dislocation that can sometimes be missed. So it needs to be a good X-ray and somebody that's competent looking at the X-ray. But for me, MRI scan. Rarely do I do it with an arthrogram or a dye injection, only if they've had previous surgery, that there's sometimes some artifact and issues, reading and the healing fibrous tissue versus re-tear. So a standard dislocation for me gets an MRI scan, and oftentimes, unless it's a recent or acute dislocation, I'll ask the radiologist to include what's called an AVA view, so an abduction external rotation view, as part of that MRI series. And it's really useful at putting some tension on the inferior glenohumeral ligament and the labrum to, if you like, to separate that away from the front of the socket to confirm whether there's a tear there or not. Not so useful in the acute setting. In the acute setting, the shoulder's going to be full of blood and fluid, so it will typically show that tear early on. But yeah, for me, an MRI scan, and every patient that sees me, whether it's a sore shoulder, frozen shoulder, arthritis, rotator cuff tear, I want to play an X-ray on everyone. I don't want to miss any of those very rare lurking bone tumours or calcifications or other things that you can see on an X-ray. So long-winded way of saying an X-ray and an MRI scan for me.
Yep. And if you see someone that has had a dislocation previously and they present to you 6 months after that dislocation, are there any clinical tests in your rooms that you can do that may help you diagnose a labral tear or the like that you would get from a dislocation?
Yeah, absolutely. So when I'm examining the patient in that setting, I'm looking at their instability, but I'm also looking to make sure there's nothing else going on. So that'll be the important things I'm really looking for. From a clinical examination point of view, the instability testing is probably the less important for me, in that they come in and they've told you they've had a subluxation or a dislocation. Of course, you want to work out the direction, but the imaging is going to give me the answers for everything I need to know on that. So for me, I want to know what their range of motion is. So I want to know that they haven't developed a frozen shoulder secondarily, another problem in the over 40s when they have a dislocation. From a pure instability point of view, I want to know, do they have any posterior instability, which is, there are a number of tests. The jerk test, bring the arm in front and turning. For me, it's a beautiful test for posterior instability, and I also use it to see whether they've recovered satisfactorily with non-operative management. Is simply just to bring the arm, a bit like a Job's test, but bring it in front of the body with the thumb turned down, and do resisted testing. And if they can resist you and they feel strong and confident, then you can assume their rehabilitation's been successful. Doesn't mean they can't have a re-injury, but if they come in and do this and you push and they just can't resist because they don't have a fulcrum without the humeral head going out the back, then that's, for me, a worrying sign that their shoulder's not, if you like, quote unquote, recovered. From an anterior instability point of view, I mean, my testing for that is, I simply lie them down on their back and I do a standard apprehension test to see whether they dislike that, and then I'll do a relocation maneuver, which is to put my hand on the front of the humeral head, pushing it, if you like, back into the joint, and then see whether they find that more comfortable. And then if you take your hand off gently and they don't like it, then that's a positive test. So that's, for me, if you like, the clinical exam that I'll do. But if a patient comes in and says, I've recently had a dislocation, went to hospital, it's put back in, I want to test that down the track, but probably not acutely. It doesn't really add anything in the early phase. But 6 months, I want to see whether they really are truly unstable, because they might say, my shoulder feels pretty good, but you lie them down, do that, and they have that reaction, or they're unstable, then that's all part of the information gathering to be giving them advice about what to do.
And you're gathering more information, I assume, at that 6 month mark with X-ray and MRI, as well as obviously the clinical tests in the room.
Exactly. So that's going to tell us what the pathology is. So yes, important. I want to check the cuff, and I want to do all those things. Again, the over 40s, they're more likely to have a rotator cuff tear, and if you've got a retracted rotator cuff tear, then that's, for me, that's a worry, because they're the ones that can become irreparable if they're severely retracted. So that's what you just don't want to miss. The instability, I tell them, whether they've had 1, 2, 10, people come in and see me with literally 100 dislocations. I can generally do something about that to stop their shoulder dislocating, but an irreparable cuff tear, particularly in a 40 or 50-year-old, that can be a very difficult situation to try and salvage without any really good answer for many of them.
Yeah. And using a sling after a first-time dislocation. So when I asked the question, should you use a sling for a first-time shoulder dislocation for longer than, say, 7 to 10 days to reduce the risk of dislocation or redislocation, you said no. Why?
Yeah, so it's a good, interesting question. That for me, I guess my practice and my experience has been the sling hasn't offered a lot of help. And when I guess when we all talk about sling, as you and I are speaking now, we're talking about a simple sling of the arm in a supportive position.
Yep.
I haven't seen studies that have really shown a significant benefit of prolonged sling immobilization after dislocation, nor have I really seen that clinically. So my practice is to tell people the sling's there for pain relief. Come out of the sling as soon as you feel comfortable, just avoid at-risk positions and maneuvers. But the sooner I feel I get them out of the sling, then we can start their rehabilitation, and the sooner the better. I guess my asterisk was there was a paper a number of years ago by a very well-known and respected Japanese surgeon who did a study looking at putting patients in an ER sling, and by that I mean an external rotational gunslinger brace with the arm externally rotated, that is felt to reduce the essential lesion or Bankart lesion or labral tear better. And he published, his results are fairly convincing, that he was able to show a reduction in the recurrence rate in those patients that wore an external rotation brace for 6 weeks. So many years ago, I'm going to say this was 15, 16 years ago, we were invited to be part of an international multi-center study with this guy. We just could not get paid. You've got to get the patients straight away. So it's really got to be done through an emergency department, or I guess patient or physios will look after acute care patients. So I see some that acutely, but not a lot. We found it very difficult, not just to get them that acutely. That wasn't the issue. The issue was trying to get patients to wear an ER brace 24/7 for that period of time. We just couldn't get patients to do it. Most of these patients, without stereotyping, are young males, and it's hard. The ER brace, getting them used to it, being compliant with it. So we weren't really able to achieve the goals of the bracing to get the results that they were able to achieve. So I've got no doubt their results were true. I know the lead surgeon is very honest, respected shoulder surgeon. I just think you've got to have a patient that's really compliant to do the bracing, and then accept that. I guess for me, a lot of the conversation with patients will go like this: that whether I send them to you, Andrew, to do physio, I do an operation, whatever that operation may be, or we put them in a brace and they're compliant and they're super behaved and they do well. The shoulder dislocated in that labrum tore when it was made completely normal. So the idea that whatever we do can guarantee them it won't come out again, they just need to appreciate that whatever path they go down, there's no guarantees, like there are no guarantees in life. So that's what my asterisk was there is some evidence that you can actually brace them and improve the result in an ER brace, but I'm not so sure that I've seen that with what we would all assume would be the typical brace.
Yeah. And if someone presents to you and they've had multiple dislocation events over a period of 12 months, and they're a footballer under the age of 25 and they're playing rugby league, say, for instance, and they've got a bony Bankart lesion, if they've got a bony Bankart lesion combined with the fact that they're young, combined with the fact that they want to continue to play the sport, is that someone that's potentially going to head down that surgical route based off those factors?
Yeah, I think so. And I guess, there are so many factors to decide, work out what their risk is without, I tell them I can give them approximates, but I can't tell them what's going to happen to them without a crystal ball. That here in Australia, we have a wonderful experience looking after patients with shoulder instability. If you really think about it, a lot of our, teaching comes from the States, from the UK. If you look at shoulder injuries, not say ACLs and other things, but if you really look at shoulder dislocations and the high-risk activities from a sporting point of view, well, in terms of all international sports, you would have to put rugby union, AFL, and rugby league as the top three. So they're three very common sports here. The risk of a shoulder dislocation playing, say, American football compared to any of those Australian codes of football, very different. our risk is so much higher, and therefore also our risk of redislocating after a surgery. So we've got a great experience looking after instability. So that patient you mentioned is a pretty bread and butter patient for me. I look after a lot of footballers, professional, grade, club, schoolboy. Probably the highest risk of all. Actually, they're we don't talk about it so much, but that's one of the, for me, like recently give a talk on shoulder instability, and I finished the talk with some slides on what worries me. I guess it's the young patient with instability. They've got more hyperlaxity naturally. They've got many more years of high-risk activity, particularly the young footballer. By that I mean, when I say football, I mean rugby league, AFL, rugby union.
So more you tackle.
Yeah, that's right.
Tackle sports,
there's just so many multiple chances to dislocate your shoulder. If you think about it in the game of rugby, there's tackling, there's pilfering, there's being cleaned out in the ruck, there's diving for the balls. There are so many opportunities during every game for there to potentially be a re-injury. And, it's wonderful. We're seeing now in Australia, women's football, rugby league, AFL, rugby union, increased participation numbers. And there are a lot of factors in terms of the risk there, but those are a perfect storm for shoulder dislocations. They have a degree of hyperlaxity, more so than males. I guess getting their muscle bulk is always going to be less than their males, the way things are. And then I guess their years of participation in the sport. A lot of talented girls will move to those sports a little bit later on as opposed to younger. So there are a lot of factors whereby I'm probably seeing it, and even I notice more and more female shoulder dislocations in those contact sports. And they're the patients, the young patient, the female patient that we want to do the most cosmetically pleasing operation. That's probably in those groups that and I'm assuming we'll talk about the different surgical options, but it's probably those groups that it's actually the highest risk of failing when we repair that labrum and trying to recreate the shoulder was originally designed. Yeah.
And speaking of the surgical options, let's just go through some of them. And we mentioned a few of these off air, and you said you're a big fan of the Latarjet procedure. And why is the Latarjet such a great operation, and why do you often use it for those recurrent dislocators?
Yeah, I mean, I guess there's a long history. I'm not sure how long we've got to talk about it, but it's certainly a very interesting topic to me, and I'll explain it to you probably like I do to patients, in that I tell them that over the years there have been so many different operations that have been tried and proposed to try and stop the shoulder dislocating. Over the years, I think we've narrowed it down to basically now two main procedures that we will do. One, let's call it the anatomic, low-risk arthroscopic keyhole procedure, trying to redesign the normal shoulder, which most of us would refer to as an arthroscopic Bankart, Bankart is the labral tear that occurs, so we're simply repairing that. So we're repairing the ligament, the labrum, the Bankart lesion, whatever you want to call it, the soft tissue disruption at the front of the shoulder, which has traditionally been done through an open incision at the front. But with the advance of keyhole surgery, we do it through arthroscopy. And I think most of us would say we're as good doing it arthroscopically as they were doing it open, whereas some of the surgeons that were around in the era of open surgery say that their results are maybe a bit better. I think we've gotten as good, but I wouldn't say we're better. But certainly we can also see collateral damage and other things. So essentially that's a repair.
And where are we at with the redislocation rates with both the arthroscopic version and the open?
I think we're probably pretty similar. I think the arthroscopic's approaching open. Again, there's some studies showing that it's not as good, others showing that it is. I think the consensus would be that we've gotten as good. And theoretically, whether you're opening or doing it arthroscopically, if we're able to do the same repair, then it shouldn't be any different.
Yeah.
With the exception that maybe when you do it open, you create a little bit more scar tissue through that open incision that makes them maybe a little bit tighter and helps reduce it, which is why I would say arthroscopically we're probably not going to do better. We're going to do equally well. I guess it also depends. I mean, a lot of people don't want to publish bad results, right? I spoke to a colleague of mine in New York, and he said, New York, it's tough. It's very competitive. They're not going to publish a paper showing, less good results in, say, Columbia or HSS. So trying to get the true results can be a little bit difficult at times. And I guess it's also one of those operations that the longer you follow those patients up, the more years they have of doing at-risk activities. The younger they are when they started, the more failures you will see. And so when people publish their results and they're following them up for 2, 3, 4 years, the results are good. But if you actually look at the literature, you know, for every year you add, those numbers deteriorate and deteriorate further. It depends on so many factors, Andrew. You know, like it depends on their age, their sex, their sports participation, right, left shoulder. I guess it depends on a bit of luck or bad luck as well. I guess people will often quote keyhole reconstruction, the overall failure rate's about 10% or up to 10% and maybe up to 20% if you want to call it subluxation, apprehension, all those things.
And failure means redislocation or resubluxation?
Again, depending on the paper, it's very poorly defined by a lot of people in the paper.
Yeah.
So it's a redislocation or need for revision surgery or the feeling of just unhappiness or return to sport. So a lot of those things aren't spoken about. We just talk about redislocation, but there's a whole lot more in that spectrum that patients may be, if you like, unhappy with their outcome or the results of the feeling of their shoulder or their inability to get back to a particular sport because of further subluxations, apprehension, dislike of their shoulder. And there was a study, you know, again, all those factors, we talked about those high-risk sports that we have a lot of experience with here. There was a study a few years ago looking at rugby contact sports in adolescents. And I remember reading this paper, and at the end, the likelihood, if you had an arthroscopic repair of the labrum, Bankart procedure, and you were under 16 and you played rugby, the chance of recurrence, redislocation, resubluxation was 92, 93, 94%. So you say 9 out of 10 fail. I mean, that's a terrible operation. Why would you do that to anyone? But they're the patients that are young, that you don't want to do anything more or open or, you know, change the anatomy of their shoulder. So the ones that probably need the stronger operations, we're more reticent or reluctant to do that because, you know, if it's, you know, your child and they're 13, 14, we just want to go in there, repair, make it look back to normal, do the low risk keyhole operation. But and I do that often in young people all the time. I have a long discussion with the patient and their parents at that age, but they've all got to know that they tore it when it was made normal. And I fix it. I can't make it any better. I can just hope to make it nearly as good. There's a chance of failing. And I guess when we talk about types of operation, that's been the history. You know, we've fixed that essential lesion, i.e. the tear of the labrum and the ligament. We've worked out that fails. So it's like, well, how can we make that better and reduce the risk? And sometimes people get caught up in trying to get the risk down to zero. Well, that's unrealistic. We can't have that as a goal. We have to say, well, what's the lowest level we can get it to and what's acceptable for that patient? And for different patients, you know, you're a professional footballer, your acceptance of a redislocation is probably going to be different from somebody that doesn't play much sport and does a little bit of recreational activity. So there's all those factors that go into it. So over the years, to try and make that arthroscopic repair better, you know, we've tried putting extra anchors in to make it stronger, more durable. We've tried to tighten the shoulder a little bit more by putting anchors down the bottom at the back to tighten the whole capsular volume and decrease. We've tried to close the rotating interval at the front. There's historically some success by closing that rotating interval, I guess, to tighten the shoulder or to lessen the likelihood of it coming out the front. And I guess the one addition that's probably what we're speaking about most commonly now in terms of discussion about operations is something called a remplissage. Basically, it's French meaning to fill the defect or fill the void, which is essentially sewing the rotator cuff at the back, the infraspinatus, into the Hill-Sachs lesion to try and fill that lesion to lessen the risk of the shoulder coming out. You know, there's, again, like everything in life, you look at different studies, different results, but I think the overall consensus would be in the studies I've seen comparing repair versus repair plus that procedure will definitely show that if you add that remplissage procedure, you can reduce the risk of redislocation. I don't think the results have been as good as a Latarjet, but they're better than the repair by itself. So it's sort of a bit of a middle ground between the two, where for a lot of surgeons say, well, okay, well, it's still pretty low risk. I can do that. And that's another consideration that I think people will see used more and more. It's taken a while to come into vogue. You know, it's been around for for a while, but I guess the more people are dislocating, the more we're trying to find a solution to stop that. So that's, if you like, the latest edition. It's still not going to guarantee the shoulder doesn't come out, but it's another means of trying to, if you like, reduce that risk. And that brings us up to, I guess, the Latarjet, which you sort of mentioned. And the Latarjet, it's not like a new operation. It's been around for a long time. It's almost, I think it was 1940 something or something that it was first published and described in France. There was a similar operation that people may hear called a Bristow that was described by, I think, a UK surgeon that gave his advice to a South African military surgeon, and that's where that comes from. And essentially that operation is what people would call it, a bone block. So we're taking the coracoid bone and we're screwing it into the front of the glenoid. And people quite simplistically feel that increases the surface area, or the runway, if you like, of the glenoid to give it more length before the shoulder dislocates. Actually couldn't be further from the truth. It's not how it works at all, but it's kind of a nice, easy way for people to discuss it. So it's called a bone procedure. How it actually works is, I want to tip my screen up. Apologies if I've offended people with the choice of jerseys on the wall there. The position of dislocation is abduction, external rotation. And when the arm gets in that position, the humeral head wants to dislocate if it goes in an anterior inferior direction. It actually goes under the subscapularis muscle at the front. So how the Latarjet works is by the tendon that attaches to the coracoid, the conjoint tendon attaches to the biceps. So when you cut the coracoid, you push it through the subscap, or say the middle, it's technically 2/3, 1/3 usually, but say if we poke it through the middle of the subscap for purposes of this discussion and reattach it to the front of the glenoid. So in your mind's eye, if you think, okay, so I've got a biceps with a conjoint tendon coming over the subscap, the lower half of it, and then attaches to the glenoid. That lower half of the subscap here, the more I bring my arm into that position, the more the humeral head wants to come forward, the more that conjoint tendon is holding that lower half of subscap in that anterior inferior position. So the more you bring your arm into that position, I describe it to patients, that subscap is like me doing that relocation maneuver, the more it's actually pushing back. So the more at risk their position, the more it pushes back to hold the ball in the socket. So it's basically doing a relocation maneuver through the subscap, which is being pushed by the conjoint tendon. And I'll tell you, a lot of surgeons don't understand that's how it works, let alone other people around. And so it's very difficult then to try and explain that to patients. But that's why I simplify it to them. That's, if you like, the belt and braces of this procedure. The more you get in a position where the shoulder wants to dislocate, the more this operation is going to help. Which is why I guess for patients, say, if you've got a patient with MDI, it's a segue from this, but they've got a very different beast, and a Latarjet is not going to help that patient. A patient that comes in saying the shoulder feels unstable down here, and when they reach forward and move around, well, an operation that stops it doing this is not going to be so wonderful.
And MDI, you're referring to multi-directional instability.
Multi-directional instability, yeah. Those patients with a lax ligament is very different situation in those patients. But we're, for purposes of traumatic anterior dislocation. So that's a wonderful operation. And in some parts of the world, it's essentially all they do. I know there are some surgeons in Sydney, that's all they do. Some surgeons don't do it. I guess the short summary of the difference between the two is, whilst I said the arthroscopic repair is the safe, anatomic, low risk,
easier,
making the shoulder back to normal. This is a much more difficult operation.
Sounds like it, definitely.
Yeah, it's you have to be very particular about this. There's a lot more to tiptoeing through a minefield of potential complications, nerve, irritating hardware, aggravating or causing arthritis, getting the bone to heal position. So there's a lot more that can go wrong. And I'm sure there's some architectural analogies as to simple versus complex. But if you know what you're doing, you do it well, the patient gets after it, then you can really minimise those risks. And, I know all my complications over the years. And if I really thought, there was a significant risk in my hands of that, then I'd be much more nervous about doing that operation. But in saying that, if you ask me about patients I see for a second opinion that have had problems related to shoulder surgery for instability, wow, I mean, if you have a keyhole operation and a repair, most often what goes wrong is it fails. And you can then mend that with a Latarjet or another procedure. If a Latarjet has a problem from a nerve injury, from cartilage damage, from all those other things that could potentially go wrong, then some of those problems can be permanent. So, high risk, I think most people would say it is, but it depends on who's doing the operation. They've got to know what they're doing. They've got to get it right, and they've got to avoid all those pitfalls that can occur. But in terms of results, then I joke when I'm at meetings talking about it, the arthroscopic Bankhart's my favourite operation. It's a beautiful operation, quick, simple to do. It's just a wonderful operation to do. But my favourite results would be the Latarjet. Tougher operation, more particular, more stressful. You've got to get it perfect, but that patient's going to have a stable shoulder. And the likelihood of them coming back to me with an issue or a problem is not zero. And I tell patients that I can't give them 100% guarantee with whatever I do, but the likelihood of them coming back with an issue is so much less. For me, that's why I use it. Now, I don't do it in everyone. In fact, I do a lot of arthroscopic. I probably do more arthroscopic repairs than I do Latarjet, but because I look after a lot of professional football teams, rugby league, AFL and other sports, then I do a lot of that operation for those. And same goes with schoolboy. I look after a lot of schoolboy football, rugby, AFL, rugby league. Then, I have a discussion with that patient and their parent, and it depends on what their goals are. Timing's a big issue, and their acceptance of having another dislocation. I'll give you another example. If I've got a young, 20-year-old patient that's a tradie or an apprentice tradie with a dislocation. Wow, it's difficult to have the time out to recover from an operation. So even though that patient, a keyhole operation may be a good option, if that fails, then that patient's then potentially needing to have a further operation. Whereas if I do a Latarjet, maybe their likelihood of reoperation is so much lower. So even though they may not play professional football, they may play park football, they may choose that other option when they consider all their life, the life forces at play. And again, what's right for me is not necessarily right for another surgeon, and what's right for one patient is not necessarily correct for another patient. There are so many considerations, I guess, that go into making that final decision, and the patient makes that decision, not me. I feel my role is to give them the information. I can, of course, lead them down the garden path very easily. But in the end, I feel my role is to give them the information, let them make the decision, and then make sure I do my job as well as I can.
And in terms of failure rate and redislocation rate with the Latarjet, where are we at with that? I know that's probably depending on the study you look at, and
it's depending on the study you look at and whose results they are. Everything from of course 100% results to some patients with maybe 20% failure. But I would say for most surgeons that do that and do that well and do it regularly, look, I tell patients again, it's not 100% guarantee, but the likelihood of them redislocating is really low. And I would say 95% would be a figure. But I can remember my outside of say epileptics with seizures, which whatever we do, there's nothing that can guarantee to stop that coming out. MDI shouldn't be done. And those other patients that have other collateral damage with their shoulder and some pain issues, I would say, my patients have actually had a true dislocation after a Latarjet. I can actually think of those couple of patients.
Oh, wow. Yep.
So, and I don't know how many of those I've done, but Bankart instability, I couldn't think of all of those. There'd be a lot more. So, yeah.
And when it comes to the Latarjet, what happens to the bone graft? After 12 in 12 months' time, is the bone graft and the piece of bone that you've taken from the coracoid, is it still there in situ where you've actually placed it on the glenoid? Or has it been reabsorbed by the body, or what's going on?
Oh, it's really interesting. There's a lot, and I think as time goes by, as this has become a more universally accepted operation, not just in little parts of the world like Lyon in France, that there's more studies about all those things, how it works, what happens to the bone graft. So you probably can't see it very well here in my model, but that's the coracoid, right? So we're looking at left shoulder, glenoid, acromion, coracoid at the front. So the Bristow operation really was, I guess, an easier version of a Latarjet. You just cut the tip of the coracoid and you fixed it to the front of the socket. A lot easier. Initially, it wasn't with any fixation. Then they used one screw. What people accept as a Latarjet now is you take a bigger piece of bone. So you take the majority of that horizontal coracoid, you turn around, prepare it, and you fix it, if you like, the the length. So it's usually that graft is a couple of centimeters, and we'll try and get a longer graft to fix to the anterior part of the coracoid. So it's about 2 centimeters or most of the length of the coracoid. And usually fixed with two screws or buttons or other things to try and get it to heal. And we call it a bony procedure, and everyone calls it bone grafting, bony procedure. But if you think about it, as we talk about how that operation works, that bone is really, the aim is to attach the conjoint tendon. I've often said, if I could get the conjoint tendon to attach without the bone, yeah, I'd just cut it off and fix it. But getting tendon ligament to heal the bone, it takes a long time, very difficult, not so reliable. Whereas getting bone to heal the bone, very reliable. And people are breaking bones all the time. As a general, they heal with or without an operation. So getting bone to heal the bone is much quicker, much more reliable. So that's the best way of getting it to fix. And the purpose of using a long bit of bone with 2 screws is you've got more surface area to make it a stronger repair, more likely to heal and stronger. In terms of what happens to the graft, that's the interesting part of that. So if you've got, again, probably doesn't project here well, but if you like, the glenoids is like an egg type shape with a central circular portion with an extra bit at the top where the biceps attaches. When people have a dislocation, this is the anterior part, anterior, where they tear the labrum. But if they've got a bony banknote or they're missing bone here at the front of the glenoid, and you reattach bone, then that bone can be loaded, and so that bone can remain. If, say, we did it in this patient or this shoulder where there was no bone loss, well, that bone that I attach at the front isn't going to be loaded by the humerus because there's no bone loss. So the top part, according to Wolff's law, which is bone remodels according to the forces across it, will actually just resorb away. The bottom part, interestingly, stays there. And the reason for that is it's attached to the tendon. And so it is under a tensile load, but it's under loading. So when people used to do the Bristow, the small bit of bone, that bone will just stay there, look like a little bit of an index finger projecting from the front. But with the Latarjet, with a long piece of bone like this, typically the top part partially resorbs away and the bottom part stays there. But if they've had bone loss before, it remodels back to where the amount of bone. So the shoulder tries to recreate its normal self according to loading. So yeah, a lot of that graft will actually resorb, but past the time point when the bone's healed, and given that it's only resorbing because it's not in contact, well, it doesn't matter that it resorbs in that sense.
It's a great answer. And for the listeners out there listening via a podcast channel, this will be on the YouTube channel if you wanted to watch Allan go through that explanation, because that was phenomenal. Well done. Loved it. And with a sling post Latarjet, what are we doing with a sling? How long are we keeping it on? What are the current recommendations?
I guess it's, that's where there's some variation. And when I speak to physios or sports physicians, other surgeons, I don't think any of us could say we've got the answers. We've got what we think the answers are, what we believe, and there are a whole lot of factors that have led to us coming up to that answer. And that goes for rotator cuff, shoulder replacements, all these other procedures that we do. So all I can speak about is what I do, but I do see variations on the theme. I guess if you do the operation well, you have a long piece of bone, you have secure fixation, a sensible patient, then, I'll get my patients out of the sling when I see them at at 2 weeks for their wound review. And for me, the benefit of that is they don't get as much atrophy of their muscle. They can start moving their shoulder. So it gives them a better platform for their rehabilitation and their recovery, particularly if there's a time frame of return to sport. I also get them doing immediate full range of motion, and they don't have full range of motion that first couple of weeks, but I get them moving to start working on their motion to kickstart that, but also that little bit of movement. I tell the patient it's not their rehabilitation as such, but it's stopping them losing some of their muscle tone and bulk to make their rehabilitation when it starts a lot easier. So for me, I get secure fixation, I get them going very quickly and get them out of the sling. But if I'm in there and the bone's not so great, the patient's not going to be so compliant, there's other things that I repair that I might keep them in the sling, for another week or two, up to 3 or 4 weeks. If I do a keyhole or a standard label repair, then I think most of us will keep them in the sling for 4 weeks, with some people still going with the traditional 6 weeks, similar to rotator cuff. Many of us have been 4 weeks, traditionally it's been six weeks. So the advantage of the Latarjet, again, going back to, the differences between the two operations and why some patients would choose a Latarjet, it's not just in terms of the recurrence rate, in terms of the recovery time frame. If there's a desire to get back sooner, then I can definitely get my Latarjet patients back quicker than I can my repair patients back with confidence that that shoulder will be okay. And again, I explain that to patients. I say that bone to bone healing is quicker than soft tissue to bone healing. And once we get the bone healed, then we can work on the muscles and get everything else. They're not back playing as soon as the bones heal, but I certainly get them back a lot quicker to their sport.
And for a patient that just doesn't use the sling, you ask them to, and they just don't use it at all. What's going to happen with that? What's going to happen with that patient? Because I guarantee you've had heaps of patients that never use the sling because they're shockers.
I never say it to them, but I tell their mum. I say I'm not going to tell it to them, but I know most of these kids don't. I say as long as they don't do anything silly, like I tell them it's that bit of bone I've fixed is attached to their biceps, so they just can't do anything sudden or forceful with their biceps. No lifting, no pulling themselves up. Over the years, I've seen lots of patients with bone grafts that are broken, fractured. I've had two myself, and one was a professional boxer that a couple of weeks after the operation, before he was supposed to be in the sling, he didn't wear his sling at all. He drove himself home from hospital the next morning, and he was on an earth moving machine, and he slipped and fell off the wet car in the rain and grabbed his operated arm and pulled the bone graft off. And the other one during COVID lockdown escaped Sydney and was on the Gold Coast, and said he had a bit too much fun and a bit too much to drink and tackling somebody in a pub after his operation. But they're the two examples of with extreme force. But of those other, I don't know how many patients have done that operation. But yeah, you bet a lot of them aren't wearing their sling. They're doing stuff they're not supposed to. And it's a pretty strong reconstruction. But I don't tell that. I tell them the horror stories about it. I always tell them about the two. But that they realise that they do have to look after it. But same with the rotator cuff repair. I know a lot of patients. I tell them not to do anything too forceful, swimming, all those other sports until 6 months, and they come back at 6 months and they tell me how good their shoulder feels already swimming. And so, I definitely know, and we're relatively conservative. We want to sort of try and minimise the downside of complications, failure, and so I guess we do err on conservatism in terms of our recommendations for sling. There was a paper recently. We published a paper here, my partner and I. Ben Cass, on time in a sling after rotator cuff repair, and small tears, not retracted, not big, single tendons. We got them out of the sling by 2 weeks, and all my patients healed and they were fine on MRI follow-up. But I wouldn't say do that for a big tear, an unreliable patient, or all these other factors. So I've got to be a little bit careful about sling. And there's a recent study where they didn't use a sling at all, and they had pretty good results. Not 100%, it was 80-something% success. So if you've got a compliant, sensible patient that's not going to do anything silly, then the sling is probably providing a little bit of, support, pain relief, letting the wound heal. And for a couple of weeks, I think most patients can tolerate that. It's getting them out to the 6 weeks. That's when it starts to get difficult.
I think the key word there is sensible.
It's hard to find a sensible footballer, but I shouldn't say that. I've got a number of very sensible footballers, of course.
One issue you may have, I assume, over the years with Latarjet is with throwers. So losing external rotation, because they obviously will like the amount of external rotation they get because of that cocking sort of position that you want to get into when you're throwing, say, a water polo ball or a baseball or a cricket ball. So if they've had multiple dislocations, it's been an anterior dislocation, and they're potentially a candidate for a Latarjet.
Yes.
But they want to still be a great throwing athlete. Does that completely change what you do?
It's again interesting. I guess it depends on how the operation's done and depending on what paper you read. And there's some papers showing that the loss of external rotation is actually greater in patients with a bank cut than it is with a Latarjet. Other studies showing Latarjet they can lose motion. I often say, I'm very happy looking after the type of athletes we have in Australia, where we're predominantly contact collision type sports, without so many throwing sports. As you would say in the States, overseas, even in Europe with European handball. What I've learned and discussed with my colleagues in those countries is it's very difficult when a patient truly has a dislocation, they've got a Hill-Sachs defect, they've got a tear, you fix it, whatever you do, to get back to elite throwing, where they just don't need normal ER. They need, like say, for a baseball pitcher, whatever you do to feel that you can give them a good, strong, stable shoulder to do that, it's hard. You look at any professional, I guess in terms of pitchers, quarterbacks, I mean, they don't dislocate their shoulder often in those sports. They might have some labral tears and other things, but if they have a true dislocation in a younger athlete, it's very hard. They can assume the likelihood of them becoming an elite level pitcher is pretty slim. So if they get them young enough there, they'll encourage them to change position because you're trying to get them back where they need to be. I mean, if you've got a successful repair, that heel sacks, whatever it is, even if you feel some of it, there's still going to be some rubbing on the front and that sense of that little loss of DR, but that feeling the shoulder is not quite as powerful and strong. So it's difficult with a throwing athlete, whatever you do, non-operative, operative, whatever operation you choose. And it's not just looking at bulk redislocation. As you mentioned, it's about performance in those settings. In terms of the Latarjet, my finding has been that for me hasn't resulted in the loss of motion any different. And I tell patients I expect them to get the motion back they had prior to surgery. They had a little bit of a stiff shoulder, a problematic shoulder. I tell them they may still have some issue, whatever I do up there. But I don't expect with the way I do my Latarjet to lose motion. And I think the ones that lose motion, if you keep them in a sling for a long time, it's a non-anatomic procedure so they can get scar tissue and stiffness. I say anatomic procedures, motion always comes back. But non-anatomic procedures, shoulder replacements, that's not always the case. I do a split in the subscap. So if people do the operation, again, it's difficult. Cut the subscap down and repair it. Then you've got to protect that, and that'll heal with some tiny bit like an old putty plait. They can get some loss of rotation and stiffness. If they get a bit of arthritis, depending on the operation, or you have some other complications, that can result in some stiffness. But also, getting them moving and getting back full range of motion early, I think is key. So if you do all those things, I think you can really minimise your likelihood of stiffness. But there are some papers showing some stiffness, and people will tell me that all the time about, what about you worry about stiffness? There are studies, as I said, showing that the stiffness rates are higher in the other operations. So it depends on how you do it and how you rehabilitate the patient. So I can only speak on personal.
Yeah.
So I want them to get back the range of motion they had before their operation.
Yeah, the Latarjets that I've seen over the years are typically great in terms of external rotation.
Yeah.
And surprisingly, because if you think about it, when you're describing the Latarjet, you would assume that you'd lose probably a decent amount of external rotation, but the ones that I've seen have been pretty good. However, I think you make a good point with throwers, baseball pitchers or something, when they're really cocking, their forearm is effectively parallel to the ground.
Yeah,
it's unbelievable. I played a lot of cricket and I played water polo growing up, and I get a lot of external rotation.
Yeah, so you got amazing. So your internal rotation maybe not as good, but you've moved your arc of rotation back here. My external rotation is terrible. I can't get up there. I haven't had any issue with my shoulder. It's just, haven't played those sports, haven't got that change from a young age, and people are very different. But you look at a slow motion video of a pitch or a javelin throw or a water polo, it's amazing. The position the shoulder gets into is super normal. It's not. So the idea we can try and get it back to normal, they need super normal, and they need. I guess the throwing athletes, they need flexibility, they need stability, and they need strength and control. So you're really asking a lot. Our footballers, they need, strength and stability. So, they're easy. I said they're much easier to look after. You do a bank cut, they fail. You do a Latarjet, most often fix it. You do a Latarjet, most often fix it. Of course, there are some problem patients, but they're definitely they're much easier to look after. Give me a footballer over a baseball or any day, or I'll look after water polo teams and other sports. They're much more difficult.
Yeah. One last question. So if someone...
We come to the end already.
We've come to the end. I reckon you could do a 4-hour podcast, Allan. You're great at podcasting. This is Allan's first podcast, by the way.
First podcast. Yeah.
You are killing it.
Andrew, I know a bit about the shoulder, and I'm happy to talk about, calf instability, all these things of what I think or what I've learned or what's gone into my thinking without ever saying that I know the answer for that patient. It's just giving them the information. And I also tell patients that I'll sit on a panel with other very, well-respected, well-trained, highly regarded surgeons, and you'll get different opinions.
Yeah.
So, they've got to go away and synthesize that information and work out for them what they feel is is right, and in one surgeon's hands, it may be better to go down a certain path than another path, depending on their experience and their skill and everything like that. And for the sling, just to follow up on the time and sling, I mean, it's difficult for physios, and GPs and sports physicians, because we're all different. Some might sling 6 weeks, 4 weeks, 2 weeks, be strict, start physio early, start physio
Yeah.
late. I mean, there are a whole lot of things that go to this, and people say, "Oh, why are you doing that operation when you do this other operation for these footballers?" Trying to explain the differences. There's a lot of subtleties, and I guess that's the art as opposed to the science of medicine.
For sure. The last question is this: if someone has tens to hundreds of dislocations throughout their life, they never consult with a surgeon or a physio, and they just keep dislocating and they just get on with it and crack on.
Yeah.
What's going to happen to that person? And will that prevent them playing sport through their 20s if they just, like, every time they go out and play a game of rugby, they dislocate, but it spontaneously relocates?
Yeah. I think, again, it's hard to know with an exact individual patient, but, you would say it would seem logical that the more dislocation subluxation you have, the more likely you are to develop arthritis. We haven't really shown that, as well as you think would be the case. And some people will come and see with multiple 50, 100 dislocations, and yes, they can get more subluxation, more dislocations. Probably the more likely to get cartilage loss, probably the more likely to have bone loss, but not always the case. And it would appear that it's that first dislocation, first injury, and whether you've been unlucky or not, and more or less cartilage injury, that probably determines your risk of arthritis and issue later on. And I tell them most patients will develop arthritis after a dislocation, but most often, fortunately, it doesn't turn into anything severe, significant, or result in any need for further treatment later in life. So just because you've had a dislocation, you'll probably get a bit of mild arthritis later on, is not a reason for me to say we have to do an operation to stop your shoulder coming out again. In fact, the reason for an operation is to give you a good shoulder when you're young and active. So we're not doing it because of the future. So that allays the fears of parents sometimes. Very rarely would there be a bad complication of a repeat dislocation, like a nerve injury or a significant cartilage or cuff injury, but those things can occur, but they're the exception rather than the rule. So I always qualify that previous statement with that. I guess, as I said earlier, most often if somebody continues to dislocate their shoulder, I can usually stop dislocation. I can't treat cartilage injuries very well. Rotator cuff tears I can fix if they're repairable, slap tears, all those other things are treatable. So from a dislocation point of view, the older they are, the more likely the shoulder is to want to remain stable. So the older they get, most people eventually, if you like, grow out of dislocations. You become less active, you become a little bit stiffer, you get frustrated with the dislocations, you might change your activity, how you use the arm and everything like that. Some go the other way, they just keep dislocating more and more, and then it starts happening in their sleep and they lose more bone. But we can fix those. The older you are, the more likely I am to do a keyhole operation because the shoulder wants to get stiff, more likely they are to get a frozen shoulder post-op, particularly once they get over 35 or 40. But that Latarjet I can use as a good option. And even, the really elderly patient that have big cuff tears, falls, and keep dislocating their shoulder, I'm talking about 70-year-old or greater, like, their shoulder just keeps dislocating or stays chronically dislocated, and they have pain and bad function. We've got a reverse shoulder replacement, another wonderful French invention, if you like, that we can solve that. So instability we can most often solve. It's the arthritis that some of them will get either as a consequence of multiple dislocations, cartilage injury, yes, or sometimes as a consequence of surgery or multiple surgeries and issues related to that. So, there are issues with operative intervention and non-operative intervention. But I'm not sure whether operation, you come to me and you've got an unstable shoulder, I fix it. I can give you a stable shoulder, not a guarantee that it won't come out again, but pretty confident that I can give you a stable shoulder unless you re-injure. Can I change the natural history or progression to arthritis or any of those issues? I can't tell you with confidence that I can actually change the natural history. So for me, I can stabilise your shoulder, but don't feel you have to have an operation because of what may or may not happen later on. So if you're playing footy and your shoulder dislocates, you don't want to be out of action, you don't want to be off work, you don't have an operation, I'm not going to sit here and tell you that you should have an operation or you have to. I'm just going to paint all that picture of what may or may not happen, and tell you that if the shoulder bothers you, it impacts your sport, your life, your activity, your work, and you're willing to have an operation, you're going to look after the shoulder and do what I say, then then patients will come and tell me when they need an operation. Now, if you're that same patient and you've got a retracted rotator cuff tear, I'm going to tell you you'd be mad not to have that fixed, because that may cause you issues later on that we can't do much about. So save dragging you into theatre by your ear. I'm going to tell a young patient I'd be more nervous about a retracted cuff tear than I would be about a dislocation.
Yeah.
I hope that answered. Again, very wordy answer, but that's I feel like, sometimes I wish I was an old-fashioned orthopaedic surgeon in a way, and I just say, it's broken, you need to have it fixed.
Yeah.
Make life pretty simple and easy. And some patients will tell me, what you think you would do. And someone like me to cut to the chase, I feel like I should provide them all that information, but it really is a lot to take in for you and I. It's a high-level discussion, but for patients, but I feel like I should give them at least, so I try and find ways that they can understand it and give them all the information. But yeah, I'll often have what I think is the better option for that patient. And if they really push me, I'll tell them what I think they should have done, or if they were my son or they were my mother, or they'll often ask me to answer it in that way.
Yeah, no, well answered, mate. Thank you so much for your time. It's been unreal. We've got to do a part 2 because I feel like you're born to podcast.
Yeah, great. No, I'm happy to talk about instability.
Got the gift of the gab,
all
mate.
Those sort of things. Yeah, MDI. I think multidirectional instability. I mean, that's a difficult one. In terms of finishing up instability, it's hard because whatever we do to tighten those ligaments, they want to stretch out again. And it's some of the patients that I've seen with like the saddest outcomes are the ones that well-meaning surgeons have tried to fix it and tried again and again and again and again. And it's, can end up with a shoulder that's much worse if they would have just never seen a surgeon in the first place. But there are some patients that surgery can be beneficial. And so, that's a whole nother rabbit hole to go down. But definitely, I think the overarching principle of instability without injury due to stretchy ligaments would be physio. Stay away from surgery at all costs, if possible.
Yeah, for sure. Yeah, I think a part 2, 3, 4, we should do it. Have smaller topics each time, because that was unreal, so good. Yep. And so many of the listeners will definitely reach out to me to get you on again, because I think that you brought so much to the table today. So thank you. Yeah,
I'm happy if they've got specific questions or clinical or otherwise. Then I'm always happy to talk shoulders. As I said, I don't know all the answers. I can just tell you what I think, and then for people to process that information with their own experience and come up with what they think. Ultimately, what you and I are trying to do is to try and do the best we can for our patients, and the best we can for them now, but also into the future. So I always tell patients I've got an eye on the future when I'm talking about their management, whether it be young patients with arthritis. I want me to do a shoulder replacement. I feel like I'm trying to talk them out of that operation, or the multidirectional instability patients. Yeah. And where can the listeners or viewers find you? Website? How could they consult with you as well? You're based in Sydney, obviously. Yes, I'm based in Sydney. I'm at my office is at St Leonard's. Sydney Shoulder Specialist is the office name. I assume our website is Sydney Shoulder. I think it's sydneyshoulder.com.au. I think it is, yeah. But if you Google, I'm sure if you Google my name, it'll probably come to that anyhow. I'm also I consult at the football stadium at Moore Park, where I look after Roosters, Swans, Waratahs, and a number of other teams through that location. And I've been going to Dubbo. There's a very special surgeon that's been looking after Dubbo that gets a number of us as subspecialists to go there, and I've been doing that for, I've been going to Dubbo for more than a decade to do. So I still go up there. I provide a public service and private service to Dubbo in the rural area if they prefer to see me there. And COVID, terrible thing, but one of the beneficial things that's come out of COVID is the ability to do Zoom, video conference, telehealth, particularly for those rural and remote patients. That you have to drive down and see me for something that I can look at an MRI, see them on Zoom. It's for those country patients. It really has been something that's been a real benefit out of this whole situation. The government's allowed telehealth and video conferencing to go ahead. So I do that as well for those patients who want to see me interstate or outside of Sydney.
Clocking up some Rex Airlines flights back and
Yeah,
forth
yeah.
to Dubbo. Yeah, I know it well.
Coffee or tea.
Yeah, exactly. Yeah, I've
Savory
flown
or
Rex so many
sweet.
times
Water
back to
with
Wagga.
that. Milk and sugar. I know exactly. I give the answers before they ask the questions. Yeah, don't worry.
Yeah, exactly. Well, thanks again, Alan. We'll do it
No.
again soon. Back at work next week.
Yeah, the holidays finish this weekend. Back at work on Monday. So already looking forward to the end of the year and summer next year.
Sounds good.
No, it's been my
thanks.
pleasure. It's been wonderful. Thanks for inviting me to participate. It's been great.
No worries. Thanks again. And as usual, stay strong.